you so much for coming to our session on quality of care. Before we get started, I am excited to tell everyone that this session has been selected to be on Women Deliver Live. So to the global audience who's joining us, thank you very much. We really appreciate your presence. So this is the virtual extension piece of Women Deliver 2016. So we're going to be collecting questions from the virtual audience. This is going to be quite interactive with the local audience here, but we will also be collecting questions from you around the world. So please, for the question and answers from the field, we're going to do it through social media. So if you'd like your question to be considered, please be sure to tag your post with hashtag AskWD and hashtag WDLive. You can also share your questions with the social media chat section immediately to the right of your Women Deliver screen. Additionally, we invite everyone in the room, outside the room, to go ahead and tweet and use social media to spread this event a little further. You can use the hashtag WDLive and hashtag HelpMomSurvive, hashtag LairdallGH, and hashtag ProntoWD, so that this conversation will go to a wider audience. So now let me introduce myself. My name is Sherry Evans. I am a midwife and a doctor of public health. I'm a senior maternal technical advisor for JPIGO. And I'm really pleased to bring together a selection of panelists with some expertise in simulation to improve quality of care. So I'd like to take the opportunity to let my panelists introduce themselves. So Genevieve, can you please start?
Okay, thank you, Sherry. My name is Genevieve Musokwa. I'm a nurse midwife from Zambia. I'm the president of the Midwives Association of Zambia. I've been in midwifery education for a number of years, and now I'm lecturing at a university, the North Rise University School of Nursing.
I'm Ahmed Abu Shadi. I'm a medical student from Egypt, and I'm part of Women Deliver Young Leaders program.
Hi, I'm Dr. Rashmi Aradhya. I work with Program Implementations Department at Lidl Global Health.
Hi, I'm Amelia. I work with Pronto International as a simulation specialist in the state of Bihar, India. I have previously worked as a mentor alongside supporting midwives in the public health facilities of Bihar.
Oh my goodness.
Oh my God.
What's
I
happening?
don't know what is happening. Midwife.
What's happening?
Come and help me. Come
I'm
and
not a
help me, midwife.
Come have a seat.
I want to push. Can I
Seat.
push?
I'm a nurse. I'm Nurse Jen. Come here.
Oh
Please
my
have
God.
a seat.
Oh my
My
goodness,
God.
what's happening?
Wow, what's going on?
What is happening?
Looks like.
My God.
Are you
Come and
you're
help
pregnant?
me.
Looks like you're
Ah,
about
what
to.
can I do?
Okay. So
Oh my
it looks
God.
like you're about to have a baby here. Oh wow.
I
Okay.
want to
Yeah,
push.
I see
I want
it.
to push.
All right. I'm gonna even try to get. Okay. Keep
midwife,
breathing.
do quickly.
Keep
Do you know what you're
breathing.
doing?
I'm a nurse, but I'm brand new. I haven't done this before. Okay. All right,
Oh,
hon.
gosh.
Okay.
Oh
Okay,
my
just
God.
breathe with me. Breathe with
Can
me.
I push?
Yes. When you're feeling ready to push.
Ah.
Oh wow. Oh my gosh. Oh wow.
goodness.
Oh, okay.
Oh my God.
Okay. Here you go.
Oh, do you need a
Okay.
blanket? Is it breathing?
Oh, good.
Okay.
Okay. All right. How are you doing, Mom? How are you
Is it a girl
doing?
or a boy?
Oh, it looks like you have a brand new baby girl. Wow.
thank you.
Okay, so I remember I have to come back here.
Yeah.
There's there's this cord. Okay.
My God.
You feeling any more contractions? How's it going?
Yes.
Okay, I need some
Yes.
oxytocin, right? Yes, I do.
We don't have any here.
We don't have oxytocin. Okay.
we don't.
Okay. So all right, we're gonna just keep trying to get this placenta out. I'm not gonna pull it because I know not to do that. But are you having a contraction? Let me know.
Yes.
Okay.
Yeah.
All right. First, no, I have to cut the
She's
cord.
bleeding.
Oh my gosh, there's so much I haven't done yet. Oh gosh. Okay. Let me cut
God.
this cord. Okay.
God.
1, 2. Okay. Okay. Keep breathing with me, Mama. Keep breathing. You have a beautiful baby. Do you want to try maybe breastfeeding?
What's your name?
My name is Glorious.
Oh, Glorious.
All right, very good.
Okay, we
Okay.
got that.
Okay, that's
she's
done.
bleeding even more.
Okay. Okay. So is you having a contraction?
Yeah, yes.
Okay, I'm gonna bring this up. Okay, all right. So let me know, and she's still bleeding. Well, maybe
She's bleeding a
maybe
lot.
the placenta needs to deliver. I think.
Probably.
Okay. Okay. So I'm going to support your belly here. Okay.
Yeah.
And you're contracting. Your placenta is coming right along.
Oh
Okay.
my God.
Contraction still happening.
Yeah.
Okay. Maybe you can take.
Yeah, this.
Yeah.
Okay.
Yeah.
Yeah.
Ah,
Okay.
Thank you.
Okay. Oh, look, it's coming right down. Okay, great. Great. Okay.
My God.
All right. I'm still going to support. And look, we've delivered a nice full placenta. Okay, I'm rubbing.
Yeah.
She's bleeding
Oh my
even
gosh,
more.
she's bleeding a lot.
But I'm feeling tired.
I think there's something wrong.
I need
with her.
oxytocin. I need.
Well, we don't have that here.
I'm
We're
feeling
okay,
tired.
like
Okay.
How can you
Oh
help
my
me,
gosh.
please?
Can do you have a cell
No,
phone?
I'm
Can we
feeling
call
bad.
someone?
I don't have a cell phone.
I
I'm
don't
feeling
have one
bad,
either. Oh my
really.
gosh. Okay, we need to do. I know by manual compression, but I don't even have those gloves. Oh gosh.
I think she's dead. Oh no. Because we didn't have oxytocin. We didn't have help. She's not really dead?
I'm alive.
There we go. Oh, thank you. So this is how we start our Helping Mothers Survive Bleeding After Birth training. So part of the goal of this session is to talk about simulation. I want to make it very clear up front that this is not really a simulation. This is a role play that helps engage our learners. We deliver this at a facility level, and most people have not seen a simulator such as this, and the woman will come in and interrupt the very beginning of our training. And there's lots of laughter, just as you are laughing. And if you can imagine, if you're from a facility where postpartum hemorrhage and deaths from postpartum hemorrhage is frequent, when we get to this point right here, everybody's silent. And then we bring everybody together and say, this is why we're here. This is why we're here to improve everyone's skills for postpartum hemorrhage prevention, detection, and management. And so this is the Helping Mothers Survive Bleeding After Birth training. So this session is about a whole lot more than that, but I thought that this would be a good way to sort of center the discussion and get it started. Okay, so the purpose of what we want to talk about today is capacity building of the workforce for using simulation and to improve quality of care. We've all heard of the skilled birth attendant and BMONC trainings that are 2 to 3 weeks. The Helping Mothers Survive program is designed to be a low-dose, high-frequency approach to delivering little bits of content on site. We know very well that before and after these lengthy trainings, we improve skills and we improve knowledge, but often providers go back to their facilities and they are doing the same thing they were doing before they went to the training. So how do we translate what they've learned into actual practice? Well, one of the ways that we do that is use simulation, and JPIGO's Helping Mothers Survive is not the only simulation-based learning, and we have some experts here that are using that, but using other things to improve quality of care. Simulation in training includes everything from skills practice, which some of you may be very familiar with, everything from teaching suturing techniques that you suture over and over again on a piece of cloth, so that's skills practice, and you're simulating stitching a wound, for instance, to intrauterine balloon tamponade placement, where you just practice over and over again. But then all the way up to where you have a live simulation where you want people to behave as if they're in the real setting using their real materials and supplies. And then a very important feature of this is debriefing afterwards, because that's where the learning occurs. And so there's everything on that continuum. So we have some experts here that have used or been exposed to simulation, and what my goal is to ask a question to one of the panelists and then ask a similar question and get feedback from the audience. All right, so Genevieve, I understand that as president of the Midwifery Association in Zambia, with the 10,000 happy birthdays,
Yep.
that you use simulation for maternal and newborn health.
Yep.
Do you want to tell us what that looks like?
Okay. Good afternoon and good evening to all those from all over the world. We use simulation under the 10,000 Happy Birthdays project. And the project is being funded by Ledo Global Health and ICM. And it's to train 10,000 nurses between Zambia and Malawi, 5,000 in each country, to be able to deliver and prevent postpartum hemorrhage and helping babies breathe. So how do we do that? It's very interesting in that we have 3 approaches in Zambia. We're doing pre-service training in which we supply the schools with the modules so that they can be using them continuously to train as the students, midwives are going through training. And then we also have our in-service training, capacity building, where we do simulation with all the providers who come to our training sessions, and we have 3 scenarios. The scenarios are that we have a woman coming in and we have the normal active management of 3rd stage. So we'll have a demonstration like we had here, and it'll be a normal delivery where there's no oxytocin or there'll be oxytocin, and then we have one where there's a retained placenta, and then there's one where there's an atonic uterus. The uterus is failing to contract. And then we do the low dose, high frequency. At the end of the training, we provide each district with a module so that they can be training at facility level. They're doing what is known as low dose, high frequency, meaning they will simulate a normal delivery with normal, no complications. And then on another time during their lunch break or any time when they're free, they'll do the second complication, which could be something like atonic uterus. The uterus is not contracting. And on another time when they have some time, they're doing something like manual removal of the placenta. So what this happens at each stage, even after they've left the training sessions at the facilities, they can be able to practice. So they're continuously updating their skills. They're getting better and better at it, and it makes it so much easier for them to recall. And the unique thing is that the case studies, the scenarios actually come from the facility, from the providers themselves.
Thanks, Guinevere. So you were talking also about pre-service in the midwifery schools when you started. So I'm curious if we have any members of the audience here, and if we receive any questions online, we'll take those as well, that have used simulation in pre-service training. Is there anyone? And I'm happy to pass the microphone out. So we're going to take a question, then we'll go back and forth.
Thank you, colleagues. I wanted to inquire from my fellow midwife the number of midwives that you have in each facility, because we have a problem in Uganda where you get a midwife running the whole maternity alone, and there are very many patients. There may be 2 or 3 women going in 2nd stage, and the midwife is there alone. Please, can you help us, guide us? How do you manage with the staffing in maternity?
That scenario is equally true for Zambia as well. But what we're doing in our training programs is that we're also training clinical officers, and we're training registered nurses or enrolled nurses, people who don't have the midwifery qualification, because sometimes we know that they're the ones manning the labor ward, and they're the ones who are providing that care. We have a very good case scenario of one registered nurse trained in a place called Ikalenge, and she's been the one who's rolling out the training to all the others using the simulation package. So that scenario is very common in 3rd world countries, and we're one of it. That's why we've extended our training sessions to other providers who are not midwives.
And I think Guinevere has brought up a really good point, and the goal of this is actually team training. If you train just the nurses or just the midwives or just the doctors, or you segregate that training, when you come together at the facility level, you are not going to work as a team, and that's one of the gifts that simulation gives us. Back to pre-service education. Taha, I understand that you are in medical school in pre-service. Can you give us some examples of how simulation is currently used, and potentially in ways that you think it might be used better in medical education?
Okay, so in my education, I've been exposed to some simulations, for example, on emergency medicine, specifically on knot tying and CPR. Yet, I'm not exposed to enough simulations on obstetrics and gynecology. More importantly, I'm not exposed to enough simulations on the perfect doctor-patient relationship. And we as doctors, we should be able to empower women to decide what's best for them. Finally, I would like to say, it's not only about what simulations I've been exposed to, it's also about how I'm exposed to them. Mainly, we're learning of these simulations to be able to pass the test. However, we're not able to actually put these knowledge into practice when people's life is at stake. It can't just be about grades.
That's right. It's not just about grades. Okay, thank you. Thank you for that. So again, moving to the audience, do we have anybody in medical or midwifery pre-service education that might be using simulation? Do we have anybody who, yeah? Can I ask you to come up? And
It's not me directly, but we're supporting thank you. It's not me directly. I'm from the Swiss Red Cross. We're supporting one of our projects, the government of Laos, who is having now a new program that they want to educate community midwives. And I've just been placing an order at Lærdal to buy another couple of Mama Natalies. And they really want to integrate it in their midwifery education program.
okay, great. Thank you. I think we can take another question.
I'll just respond to what you said. We had a very interesting experience in Vietnam a number of years ago, where by including simulation in the educational process and also in the examination process, it really drove the students and the faculty to be much more engaged in experiential learning, because the students realized that if the skills were going to be had to be demonstrated on the exam, then in fact they got more motivated to learn the skills and to understand how to act in different scenarios. But they then demanded more of the faculty, because they said, you're going to test me on these skills. You have to show me. You can't just give me knowledge and facts. You have to let me practice, because you've told me that that's what you'll expect on the exam. So actually, I think by putting it on the examination, but making it realistic and making it actual experiential, we can drive a little bit more enthusiasm from both the faculty and from the students.
Thank you. That's actually a really good point. So, grades matter. There's another?
Hi, Liana Sarkisian, World Vision International. We have a program that we support government of South Sudan, now in Zambia, and then moving on, that we work with the Ministry of Health to bring in professional medical volunteers to work side by side with local healthcare professionals. And actually, this is the in-service capacity building, basically, that we promote. And we have a session later this evening that we're discussing our medical service volunteer program that we did a case study in South Sudan, that how effectively, in a very short period of time, it really made a difference in terms of reducing neonatal deaths because of that hands-on, on-the-job skills training from Western medical professionals passed on to local healthcare professionals. So that's just another model that works in service capacity building.
Okay, excellent. So you're bringing up in-service training. So Rashmi, I know that you have experience in clinical simulation and in-service. Can you talk to us a little bit about that?
Yeah. I was involved with maternal newborn health training programs since 2013. And when we were designing these programs, and what we thought was, it's not just important to pluck out people from a facility, bring them to a center, train them, and then send them back. It's so much more important to train them as a team, because at the end of the day, when in a labor room, let's say, they respond to a situation as a team. It could be, a helper, it could be a nurse, it could be just an assistant or a doctor or a specialist. And so they need to work as a team, they need to learn as a team. So what we did was we then bring people to a training center, but we took the training to their center. And we carried Mama Natalie, Neo Natalie, and, multiple simulators to the facility, and try to gather as many people together, including the helping staff, because they are also an important part of the whole team. And then we train these people as a team, and they learned it as a team. So be it postpartum hemorrhage, so everybody had a role to play. So, be it just calling for help, the nurse need not run to call for help. It could be just the helping staff. So, and we did this in a simulated environment. And after, there was this training for 2 days, which was like a crash course. And then we left these models in these hospitals. We didn't take them back with us, because these are low-cost models. We left them back there. And then we encourage them to try and use it every like 15 days for resuscitation on a daily basis, just so that their confidence increases. And the aha moment for most of these people was when immediately after training, like, at least one or two people had a case where they had to resuscitate a baby or where they had to manage a case of postpartum hemorrhage. And they did it by themselves without really calling for help from a specialist, which earlier on, they would be, just trying to buy time and wait for the specialist to come. And so that sort of improved the confidence levels. And what happened was, over a period of time, they realized that, practicing on these models and simulating as a team in the labor room itself would actually increase their efficiency to respond. So the response time is much lesser compared to what they used to before. And in one of the when we started intervention with one of these facilities, they had no newborn deaths at all in the first 6 months, which was so unlike earlier, where they would refer a really bad case to a higher facility, although they would not have a newborn death there, but they would refer, and the referrals really drastically came down. They were able to resuscitate almost 12 babies in a period of 6 months, and this hospital was having about 150 deliveries a month. So, small successes actually builds their confidence, to take this up on a regular basis. It could be daily, it could be once in 15 days. So, for example, if it's postpartum hemorrhage or regular deliveries, for example, they would do it once in 15 days, once in a month. But resuscitation was something that they would do because it's just 1 minute, golden minute. So every time they walk into the labor room, everybody just practices for 1 minute, then gets into the labor room. So when they actually come face to face with that incident, it's muscle memory. I mean, they respond to it without really thinking about anything, that what's step 1, what's step 2, what's step 3. I mean, they know what comes one after the other because they've been doing it day in and day out. Like, once every day is what they practice. So they're so much more confident. Not just that, but, the turnover of nurses is so much in countries like India, where there's a fully trained nurse. She works there for 6 months, and then she's transferred to another department. And then there is a nurse who comes in who has no experience in labor room or conducting deliveries. And then what do? For the first 6 months, there's a couple of complications, and then you decide to send her for an in-service training. So what is happening now is the bunch of people who are left behind are using these models to actually train these new nurses who come in, on, okay, this is how we do, a normal delivery, this is how we do Amstel, this is how we manage PPH, resuscitation. So instead of waiting for them to actually go for a proper in-service training for like 6 weeks or so, they're getting trained by their own peers. So that's in-service training and simulation put together. So, and probably that's also the way to go. It reduces the costs of training, it improves the efficiency, cost effectiveness of the training programs itself, and most of all, saves life.
Yeah, and so Rashmi, you're bringing a really good point about the locality of the training and the practice. So if it's seated within the facility, as she said, if somebody moves on, if that's the culture within the facility, to be learning at the facility level, when new staff come in, they can be updated as well. And the other piece of that you mentioned is this low-dose, high-frequency approach, not only to training, but to practice after training. As everybody here knows, if you play a musical instrument or you play a sport, the more you practice it, especially in small doses over time, the more likely you're going to consolidate those skills. And so that's actually really important. At the very beginning, you said something really interesting, though. You said, we had simulators in skills centers, but we took the simulators out to the people. It seems in our discussions here with various people involved in simulation at Women Deliver that we have heard the buzzword of skills centers or skills labs. And so in discussion with the team here, I'm curious how many people either have skills labs as part of their programs or simulators at their offices or facilities where they work. we have, keep raising your hands. I wish I could see those in the global audience because I'm sure there would be even more. Okay, so leave your hands up. So go ahead, leave your hands up. So of those who have their hands up, how many know that their simulator has been used in the last week? Leave your hand up. So number of hands dropped. What about in the last month? Okay, all right. Yeah, so, you can see some of those hands dropped because, they're not necessarily where people are. They're not necessarily where providers deliver women. And so it's not that there's no place for workshop delivery of training and simulation, but there's a huge advantage to moving into the facility level. So let's focus a little deeper, take a deeper dive into simulation itself. And so, I know, Amelia, that you have experience with simulation and simulation training and learning, and it's facility-based. And one of the things that we hear is when you do a simulation in a team of coworkers, that the important thing is debriefing. So you have to sit down as a team and talk about what you did right and what maybe you could have done better. And that especially where there's a hierarchy, that sometimes that's a challenge because maybe the nurse doesn't want to point out that a midwife or a doctor did something wrong. So I know there's a whole lot of thinking about what makes that successful. So do you want to share with that?
Yeah, sure. Good afternoon. So in Pronto, we do simulations at facility level to train nurses and doctors. And we videotape that, and we use the videos to be able to give, to be able to allow the participants to observe and reflect on their performance. So as we said that sometimes because of the differences in personal and professional cadre, there might be some difficulty in acceptance. So what Pronto does is, and what we suggest is that we do teamwork and communication activities before doing simulations. We particularly incorporate team steps into the activities, like giving more importance to some of the major components like leadership and situation monitoring, mutual support within the team, and using communication techniques. These team building activities help us, is a very important, it gives us a very clear understanding of the dynamics of the team and how well they'll be able to function as a team. And we use these team building activities well ahead before we actually dive into simulation and clinical skills and practice. So to talk about a few team building activities which we do, to name a few, like the human knot, helium stick, and so if I have to, describe more, like in helium stick, we have this lightweight stick where we ask all the team members to actually support this lightweight stick with their index finger, and they have to not lose contact, and they have to bring it from the waist level together till the ground level. So as they do these though it looks easy, there's a tendency because it's really lightweight, there's a tendency to lose contact and fall. So we tell the team to think of it as the mother and the baby and to work as a team to bring that down. So in these team building activities, they recognize how to work together, how to anticipate and to clarify each other's role. They identify a leader who assigns and who clarifies each other's role and work towards the common goal. And in these team building activities also humbles each other, and they recognize each other's strengths and accept each other's differences. And following this, we encourage them to incorporate these components which they learn through team building activities in the simulations. So in simulations, we expose them to manage obstetrical and neonatal emergencies, and following the simulation, we debrief about how they handle the scenario. And one of the major components we discuss about is how was the teamwork? How did they work as a team? Was there a leader? Did someone actually take up a leadership role and clarify the goals and assign tasks? And as ma'am said, it could be just the ward attendant, the family member. Mostly in India, sometimes we just have 1 or 2 nurses and a ward attendant, a family member there. So it could be just how she is able to delegate tasks among them, and how they're able to anticipate each other's needs and mutually support each other and use communication techniques effectively to avoid errors. All these things we are able to debrief, and further carrying on, we were able to see that Pronto's strategy was actually able to bring about change in real life practice. To give an example, just 2 weeks back, I visited this facility, this district hospital, where we had a lot of differences among nurses. Like there are some nurses who are qualified as a midwife and some as registered nurses. So they are not willing to work together because of seniority, hierarchy, and doctors and nurses with difference in their understanding of protocol. A lot of problems were arising in that facility. So we did these team building activities. We went on to do simulations and debrief about how to improve the team, and we actually saw improvement. Like recently, we had a patient with incomplete abortion who was already in shock. With the BP was not recordable, and even before we went there, the head in charge, the nurse, she called all the other nurses, and she called us also, and she was assigning tasks to all the mentors and us. She was saying, can you please start line? Can you please give Utrotonics? Can you call the doctor? Can you please arrange for referral? So in a facility which was really not working at all together, who are not willing to even being posted together, not willing to enter the duty room together, they started actually working as a team and started handling emergencies, and we could actually resuscitate that patient within 10 minutes. Usually it is 45 minutes and 1 hour, but actually we could see that improvement and effective management in real cases too. So so to be in more precise ways, we have actually seen them accepting each other in their differences, willing to work alongside, and we also do debrief of live cases, and there we have seen them take responsibility for errors or poor outcomes as a team, more than blaming on one individual, and trying to and they are also coming to clarify goals. Like they clarify goals, and they are understanding the common goal in any particular situation. Also has seen a lot of improvement, and that way we have felt that team building has really made a difference in managing emergency scenarios. If you'd like to see a simulation, you can come by in the labor ward today in the exhibition hall at 4:30 p.m. And tomorrow we have a workshop at 7 to 8 a.m. Where we are discussing how to run and design a simulation. So.
Okay, thanks, Amelia. So she's talking about the importance of debrief after simulation and teamwork as well. So I'm curious, is there anybody who runs active simulations with debrief in the audience who might like to share what that looks like?
Firoza, midwife from Afghanistan. Luckily, we have simulation part of pre-service education for midwives. They have fully equipped skills lab where they are exposed to simulations. As Jeff mentioned, so it's part of their final clinical examination. And as well as part of the in-service training for healthcare providers. And in addition to these two, we have simulation part of mentorship program for midwives. And after each simulation session, though it is on module or on patient, so they have debriefing, and the whole team sit together and they feedback each other their strengths and where they need more improvements. And we, yes, I do agree with their points and focusing on it really works. You see very tangible result. You see reducing time to manage a case, and it also task delegation, and even it creates enthusiasm to work as a team.
Great, thank you. So is there anyone else that would like to share anything about debrief? I see something. So specifically, it sounds to me like there are challenges to doing debriefs, but there are definitely ways to manage them. Okay, there you are. Thanks.
Yeah, my name is Lynn Velchirwa from Malawi, a midwife. I've been exposed to simulation, both pre-service as well as in service. What I want to comment is, I have this feeling that simulation alone, without mentorship, is not really that successful, because the experience is different on a mama natally or a neonatally and on a little mother or a little baby. So what I would like to request is that we need to identify experts in those skills that you are simulating. They should be following up those healthcare providers, like to ensure that those skills are really rooted in them. Because if they are not mentored properly, they tend to go back to their old usual practice. Yeah, thank you.
That's a good point, for sure. So I think so before we open to question and answer, I guess now might be a time to segue to see if we have any questions from the global audience that we need to answer. And they will let us know if we do. Okay, so does anyone want to say something more about debrief? And then I think we can open to question and answers.
Yeah, I would like to share some experience from Bangladesh. We are actually developing community skill birth attendants in a remote district of Bangladesh, and they have been training using simulation. And after what we did is that we have set up a skill lab in the sub-district level facilities, and where they have this all these kits for the simulations, and also their mentors, their supervisors were posted in the sub-district facility. They were tested on the same kit. So what happens in that, after they go back after the training and after their exam to the field and do the deliveries, there are some cases or some complications that only happen maybe very infrequently, happens not that frequently, and when they actually have that kind of maybe 5 or 6 months of experience, and they go through this quality assurance cycle, 3-month cycle, and there are nurses who actually observe them in the field, and also they have their own experiences throughout this period, and they come back to the sub-district level, this skill lab, and they have, each of them have their own problem, and they also consult their mentors who are trained similarly. So they have, they can even contact them over telephone. So what happens is that both the trainers, both the supervisors and these CSBS, community skill birth attendants, having the similar training and similar kind of mentorship or discussions, and how to communicate with each other, that helps providing customized support and improving over time. So that's very helpful, following up and monitoring over time, and then following up and refreshing the knowledge, customized training. Yeah.
So I think both of the participants here have brought up the point of, the importance of quality assurance. So if you're doing that with clinical mentoring or someone who will help ensure that practice that proceeds and simulation that's done correctly, so they don't fall back on bad practices. But also you brought up the point about what we call low frequency but high criticality events. So if you have something that doesn't happen very frequently, that's probably something you need to focus on a little more. So with helping mothers survive bleeding after birth, we teach active management of the 3rd stage of labor, but technically you're practicing that every time you deliver a baby, right? So once you have that down, you should be good. But bimanual uterine compression, you might not use as often. So that's something that potentially needs to be practiced more. And I feel the same with newborn resuscitation, with helping babies breathe. If you can get providers to practice before going on every shift, that's great. We find barriers in the field that, I don't have time for that, even 1 minute, and people don't do it. But that's something that they might not do as frequently and maybe not have the confidence they need to do it. And so how do you build that ongoing practice together with a clinical mentor or a peer practice coordinator or somebody who can help assure that the skills are being performed correctly at the facility level? Okay, so I'm thinking that the Women Deliver staff will let us know if we have any questions from the field. And it looks like we are fine. So let's open it up to general questions because it looked like a lot of hands went up. So I'm going to pass this.
I'd like to quickly comment on.
Yes, okay, go
I
ahead.
just wanted to comment on my Malawi colleagues' comment on mentoring. I think the mentoring aspect is really, really key when you're having providers being trained at a facility and then coming back to work in the field. So what Zambia has inbuilt into their program is that we do have mentors who are the master trainers at each and every district. We have 2 or 3 of them. And most of all, what we've done in the program is that we've made sure that the mentor is someone who's the provincial MCH coordinator or the district MCH coordinator, because she has that role to actually follow up all the midwives or all the nurses in her district. And by the way, I don't know if I mentioned, Zambia and Malawi are doing the joint project of the 10,000 happy birthdays, and we have to train 5,000 providers each, and we're doing very well. We've reached 6,000 as part of our target, and the project has been really comprehensive, and it's been very integrative in terms of ensuring that we've got the doctors on board, the Minister of Health on board, the Minister of Community Development on board, and it's one of the projects that has been a success story.
Okay, great. Thank you for that. Okay, so I think we'll open it up to general questions from the audience. Yes, from the side over here. So they're gonna handle, so I can decrease the running around a little bit.
Thank you. I'm Florence from Northern Region, Uganda. I remember we had training by the Japaigo about life-saving skills from here. And that life-saving skills was drawn to all other countries. Now, my request is it possible for us to give the same skills that we have learned to other countries? Because what the midwife does in Malawi is what the midwife does in America. Is there a possible way for us to share this together? Because not everybody has come from Women Deliver.
So I'm not quite sure the question that you're asking.
I'm saying that we have had this conference since Monday. Is there another way, any means that we are going to share this with others who have not been able to come? This is what I'm trying to say.
Yes, yes.
Because I remember we had the same program about life-saving skills, and it helped up to date. In Uganda, life-saving skills is doing very well. And the mentors are the ones conducting these trainings. So I'm requesting, if there's any means that Women Deliver with this conference should give the same information to other countries all. Because what the midwife does from the other end, even the one from the central does the same. Thank you.
Thanks for that. So I do know that the Women Deliver organizers are creating something called Solutions Panoramas. And basically, they're going to take all the best learning from all of the sessions, of course, not just this one, and the various innovations and tools and things we offer. For instance, the Helping Mothers Survive training modules and all of Japaigo's learning materials are available for free online to be downloaded and accessed. And I know with Pronto and Laerdal, the same is going to be made available through the Women Deliver conference. So those in other countries will have access to what you're learning today. Okay, other questions? We have a question from Oh, yes, okay. Yeah.
Okay. And we have a question online. How do you capture success of these trainings through data?
Okay.
Always an important.
So we'll take a couple of questions and then we'll field them. Okay. That's the only one? Okay. So there was a gentleman over there had his hand up. Okay.
Hi, good afternoon, everyone. My name's Ross Bailey. I work for an organisation called WaterAid, and I'm sorry, we're the ones who've been harassing you with a giant poo that's been wandering around, if you've been wondering what that's all about. But it is a serious message, trying to get the elephant out of the room, that sanitation, water, hygiene affects all of the midwives and all of the health practitioners here. I just had one really quick question. I've just returned from India, and I met a doctor who told me that he regularly cleaned his own delivery room. I was just wondering, from a sort of capacity standpoint, what are the sort of allied services that you think that we need? Because I've heard a lot of talk about midwives here, and obviously clearly incredibly important, but if you're being held back by doing jobs that should be done by others because there's no funding, there's no sustained monitoring of those work, is that not holding you back? And how can we move forward on that? What's needed? And that's a very genuine question to the people in the room that I want to learn from. So thank you. Essentially the question being, how do we need to support other services to support midwives?
Okay, and let's take another one from over here. Yeah. Okay, and then
I don't know if it's
okay,
working.
so we'll take yours, and then the woman back here in the corner, and then we'll go for a round of answers.
Okay, hello,
Please.
I'm Marina Manger from the Dutch Red Cross and worked at different places as well. I want to ask, because we're talking about simulation, how does that fit in with other activities? For example, are you, you talked about debrief, but are you having morbidity, mortality meetings, or this fits into a larger picture, and it would be nice to hear more about that.
Okay, thank you.
Thank you. My question is similar to the last one. It's about how do you sustain the gains achieved through this training, either in service or pre-service, through supportive supervision that oftentimes probably comes from the district health management team or others. And any examples, especially I'm interested to hearing from the field, how does it work, whether or not those are integrated into the capacity building strategies in terms of sustaining human resources for health?
Okay, thanks. So let's get started on these. I think I'll take the first one because I'm just fresh back from Uganda in a dissemination meeting on exactly the question of how do you capture the success of the training through data. And it's a challenge, but it's really exciting. So the way we did our program in Uganda is that we twinned bleeding after birth and helping babies breathe. So it was an implementation project, but we did have a randomization in 3 study arms. And what we were looking for was the clinical mentor support to training, and did that improve practice after training, and did more practice equal better outcomes. So how do we collect the data? I'll say as the PI, in my first large project, I had way too many tools, and so my analysis team is still digging through data. But it's a blend of activities. So we did the routine health information that we gathered that Uganda already was collecting, but we also instituted our own supplemental maternity registers to capture some of those care activities on a routine basis that were not being captured. And we also used direct clinical observation before and after birth to see if there was a change from before training to after the training and practice intervention. And then we had a quiet period where we did nothing and collected data again from those sources to see was there a fall off. And what was really exciting to see is that where we had support for practice after training, which was basically, I'll describe it in a minute, very light support, practice was not surprisingly more likely to happen, and outcomes were better, including 6 to 9 months after the intervention was quiet. And in the control group, received the same training and instructions for practice, but they did not receive any reminders or support for practice. They fell off, particularly in newborn resuscitation. And so that was actually very interesting. And newborn resuscitation, I have to say, is something that is very much more technical than, for instance, doing active management of 3rd stage of labor or even bimanual uterine compression. You have to have the newborn position just right. You have to have the head extended just right. You have to have the seal. All of those pieces have to be just right. And so that does make sense that for that particular activity, it required definitely more ongoing practice. So the data collection, our goal was to see, is this effective? What supports practice? And so it was quite intensive. But ideally, we program into our monitoring and evaluation data collection activities that are in line with what's currently happening and support those processes, and importantly, have those for use at the facilities so that providers can see the gains that they're making through the work that they're doing. So it's important that data use at the facility level is very important. There was a question about sanitation and a doc cleaning his own delivery room, which made me smile. But the real question is what auxiliary services are needed. Do any of my panelists want to speak to that? Yeah,
I could take
so
that.
Rashmi?
I'll give you an example of how it started. There's no one way to do it. When we were implementing one of these maternal newborn health programs, we were given this one very difficult facility in an area which had in a hospital which had 250 deliveries a month. And this was a public hospital, and care is free of cost. So and 250 deliveries and only 3 labor tables. And because one goes and the other comes, one goes and the other comes. So, and the way these labor tables were cleaned was the woman moves out, and then the helper comes in, gets a bucket of water, pours on it, and then sweeps it off. That's it. There's no brushing, there's nothing. And over a period of time, there was blood, placenta, tissues, and everything which had sort of crusted on it. And a white labor table, which I got to know later, had become brown in color. And it was stinky because the labor room was so foul smelling that the gynecologist would refuse to enter the labor room unless there is an emergency. For regular cases, he would refuse to even enter this labor room. And when we started off the first day of the training, we got them down because to the labor room itself for a simulation practice. And I saw that, there's no way that I could lie down on that labor table. So I just called the driver. I told him that, why don't you just run to the market and get me a packet of detergent, toothbrush, brushes, toilet brush, and a couple of other things. He just got it. And before doing anything, I didn't even say anything. I said, I need a bucket of water and some decontamination solution. I just poured it over that. And then I started scrubbing it myself. And then people who were standing over there, all the nurses and the doctors and the helping staff were wondering what's happening. And then I started scrubbing, and then after about 2 minutes, they realized that, okay, she's actually cleaning it. And then, okay, one came in to help, and then the next one, and then the next one, and then everybody teamed in together. And then we took about an hour and a half to clean the labor room. And we were surprised to see that these labor tables were actually white in color. And over a period of time, what happened, and the labor room was smelling so much better at the end of 1.5 hours, compared to what it was before. And then the nurses were so happy, the helping staff was so happy with this, that they did the same thing for the rest of the hospital also, which was not a part of what our project was, but they took the cue and they did it for the rest of the hospital. So if you walk into that hospital today, it smells so good, it looks so good. And it's also very motivating for the nurses also to keep it that way. So we did this training, and then we didn't go back for a support visit for the next 2.5 months. But when we went, even after 2.5 months, we found the tables in the same state, which means that there is a catalyst which is required, and once they see value in it, they would keep it in that way. And there's no one way to do it. It's just giving them a small taste of success initially in some way, and then they would continue it in a way that they feel is most appropriate for them.
But somehow you have to keep that motivation going, for sure. And that's just one piece, is sanitation. And your question was about other ancillary services that are required, and you're right. And that's something that's part of the health system and required for health system strengthening. It's not just about one provider. It's about supply chain, and it's about sanitation, and it's about all kinds of things. So, and I don't know if there's anybody in the audience that has any comment that they'd like to bring to bear on that question. What about ancillary services?
I'm Maureen Daryang from Nepal, and we are working with Options UK and supporting Nepal government under Nepal Health Sector Support Program. And we have a program where we work with the health health facility or hospital quality improvement committee, and they use self-assessment tools, and we divided, that tools has a number of areas divided in 13 or 15 domains of quality, and they do self-assessment. And after that, they have done action plan. They follow up every month on their action plan if it is implemented, and we have to do follow up on and keep remind them to do that. And they do every quarterly for this self-assessment and doing reaction planning. And this is boosted with one-day infection prevention orientation and demonstration and working together. So this has, I think we have done in Nepal in a number of health facilities and 2 hospitals, and the quality in terms of cleanliness and different areas of domains, we found that it has improved. So I think the mentoring is very important, the skills, but for the staff to be able to do their skill practice, they need this enabling environment, where they need enabling environment as well as supplies and resources that this quality improvement process, we think, has make much more of the a boost for their skills to be able to practice.
Okay,
Thank you.
Thank you very much for that. And actually, we just have 1 minute left. I'm just being signaled since we're on camera. And so I think actually your comment was speaking to, you know, how does simulation and practice fit into quality improvement practices? And so this conversation could go on for quite some time. There was a last quick comment that Guinevere wanted to make quickly.
I just wanted to say that as providers, we need to realize that we're not working alone, and we need to get as much multi-sectorial as possible. Remember, we don't supply the hospital with water, but if you get the Ministry of Local Government and Housing and tell them that the labor ward has got no water, can you be on our committee so that they make sure that there's water in the labor ward? Where I come from in Zambia, there's Northwestern Province, and we have the mines, First Quantum Mines, and we get them so much involved, and we tell them that it's your corporate social responsibility as a mine to make sure that there's a road here, that from the ambulance needs to move on a road which is gravel, hasn't got bumps and lumps. So you find that every 3 or 4 months they come, they grade the road, because they know that the ambulance has to move the patient from their facility, because they don't have a theater, to the main hospital. And we get the local government involved in terms of water. We get the Ministry of Mines, and we are making sure that everybody knows that it is the responsibility of the community to make sure that this health facility works well.
Thank you for that. So I want to thank everyone for a really robust discussion. All of us have booths, and Taha, you're welcome to be at our booth too, the HMS booth, so you can get more information and we can continue some of these conversations. Thank you very much.